Okay, well, good morning, everyone. It's a pleasure to have our Vice Dean, Jorge Garcia, to open our event today. And so I thank you very much, Jorge, for opening our event and being with us today. Thank you.
Oh, my pleasure, my pleasure. Thank you everyone for being here. I'm gonna make the presentation both first in English and then in Spanish. Y'all's last names, if not, I apologize in advance. Well, thank you very much for being here, and I want to welcome to our discussion today on global health, social inequalities, and vaccine access, organized by the Department of Sociology. The College of Social Sciences and Humanities at Universidad de San Francisco de Quito would like to thank our distinguished speakers, Doctors Isedin Abulaish, Nate Aira, and Javier Maldonado, and moderator for this event from USFQ's Medical School, Dr. Beatriz Leon, as well as the PEGASUS Institute in Canada for its support. And we also hope that this might be the beginning of a fruitful collaboration for both of our institutions and our associate members. Thank you very much. Y nada, agradecerles a todo el mundo por estar aquí y dar la bienvenida a todas las personas y a todos los ponentes que tenemos para este evento. Y bienvenidos, ¿no?, a la discusión de hoy acerca de Global Health, Social Inequalities and Vaccine Access, organizado por la profesora Cheryl Martins del Departamento de Sociología. Desde el Colegio de Ciencias Sociales y Humanidades de la Universidad San Francisco de Quito, quisiéramos agradecer a los distinguidos ponentes, a los doctores Iselin Abulaish, Neil Aria y Javier Maldonado, y a la moderadora, doctora Beatriz León, de la Escuela de Medicina de la Universidad San Francisco de Quito. Y también al PEGASUS Institute de Canadá por todo el apoyo que nos ha dado, ¿no? Y esperemos que este tipo de eventos se repitan y sean como la raíz de una cooperación constante entre nuestras instituciones y entre todos los miembros que forman parte de nosotros. Welcome, sean muy bienvenidos y aquí estamos.
Muchas gracias, Jorge, y bienvenidos y bienvenidas a todos aquí presentes. Es realmente para mí un honor poder tener profesores y médicos tan destacados aquí como parte del panel, y como coordinadora de sociología. También para mí es realmente importante que discutimos el tema de vacunas, no solamente en cuanto a lo que está pasando al nivel médico, sino al nivel social, ¿no? Y cómo está vinculado con desigualdades. Okay, for me, it's a really big pleasure to be able to coordinate this event, and I would like to thank Erica Arteaga for her support as well with organizing this event on global health inequalities and access to COVID-19 vaccines. And I would also like to thank Maria Paula Gueron, who will be assisting us with translation, and to our distinguished speakers and our moderator today. Dr. Iseldin Abulaish is professor at the School of Public Health, University of Toronto. He's a Palestinian-Canadian physician and internationally recognized human rights and peace activist. He studied medicine in Cairo, Egypt. His specialty is in obstetrics and gynecology from the Institute of Obstetrics and Gynecology at the University of London in the UK. He has a subspecialty in medicine and a master's in public health from Harvard University. Professor Abulaish's book, I Shall Not Hate, A Gaza Doctor's Journey on the Road to Peace and Dignity, is published in 23 languages and is a national and international bestseller. Professor Abulaish has been nominated 5 times for the Nobel Peace Prize, and he is fondly known as Nelson Mandela, Mahatma Gandhi, and the Martin Luther King of the Middle East. Professor Abulaish's extensive list of awards and honors include countless national and international awards, including 16 honorary doctorate degrees, the Order of Ontario, Meritus Service Cross, and the Queen Elizabeth II Diamond Jubilee Medal, the Governor General's Medallion, the World Citizenship in Action Award presented by the Canadian branch of the Registry, the Mahatma Gandhi Peace Award of Canada, the Calgary Peace Prize, the Lombardy Region Peace Prize, the Stavros Niarchos Prize for Survivorship. And Professor Abulaish has been named one of the top 25 Canadian immigrants and one of the 500 most powerful Arabs, as well as most influential 500 most influential Muslims. And I will introduce all of the speakers now, and then we will continue with the talks. Dr. Neil Arya is a family physician in Kitchener, Ontario. He is the chair of the PEGASUS Institute and a fellow at the Balsillie School for International Affairs and at the International Migration Research Center. Dr. Arya has been a scholar in residence at Wilfrid Laurier University, founding director of the Global Health Office at Western University, founder director of the Kitchener-Waterloo Refugee Health Clinic in collaboration with the Waterloo Region Reception House, and was lead physician developing the psychiatric outreach project providing mental health for those homeless or at risk in St. John's Kitchen and Kitchener. He's also an assistant clinical professor at Master University. Please microphones if you have them on. Thank you. And just want to check. Thank you. All right. Trying to make sure everybody has their microphones off. There's some people with microphones on. Please, can you turn them on?
Kevin Gomez, please. Apaga tu micrófono, Kevin.
Okay, here we go. Thank you. Yeah. All right, very good. Thank you for that. Appreciate that. Okay, so in 2009, Dr. Arya received the College of Family Physicians of Canada Geeta Gupta Award for Equity and Diversity. And in 2013, he was given a College of Family Physicians of Canada Award for Excellence. He also possesses a D.Lit honorary doctorate from Wilfrid Laurier University, and he's a mid-career. He has a mid-career award in international health from the American Public Health Association. Javier Maldonado is a family physician and coordinator of ALEMES Ecuador, the Latin American Social Medicine Association. He is also a PhD candidate in social medicine at Universidad de São Paulo, Faculty of Pharmacology, Universidad Central de Ecuador. Javier Maldonado is also a member of the social auditing platform for the immunization program of the National Anti-Corruption Commission. And our moderator, Beatriz Leon, is a professor in the School of Medicine at San Francisco de Quito, and is a doctor of medicine and surgery from the Central University of Ecuador, with a specialty in pediatrics, children's rheumatology, and allergies at the University of Florida. She holds a master's degree in health management for local development at the Universidad Técnica Particular de Loja. So I would like to say thank you very much to all of our distinguished guests here today, and I will leave the floor open for Dr. Abulaish to begin his presentation.
Thank you so much. It's my pleasure to participate in this discussion, which is highly needed these days, about the social inequalities and vaccine access. I will start by everything in life and the next hangs on the truth. And Jesus said in Gospel of John, you will know the truth, and the truth will set you free. So we need to speak with courage and about the truth. Health, well-being, and vaccine access depend on who you are and where you are. It varies between Palestinians, Israelis, American, Canadians, Latin Americans, European, African, Asians, a refugee, a First Nation, old or young, a woman or a man, developed or developing countries. And it's based, of course, on socio-economic status and the economic situation. Health and social divides are long-standing and complex issues. COVID-19 came to expose these challenges and these disparities and the consequences of such disparities on the global health, equity, security, safety, and peace. The environment and the context in which we live, it impacts our socioeconomic status and the access and even the exposures to the virus. The political, economic, social, cultural environment, which are the root causes. And of course, they are linked to the history. So history is vital. And we are talking to medical students and to health professionals. The days and periods of colonization, occupation, and conflict, of course, they have passed and they are gone and they are over, but their shadows, impacts, and the results remain inherent, engraved, accompanying, and are reflected in all aspects of life, including health, political, social, economic, and cultural. That's why history is important. And in medicine, we teach students to take history of the patient. For what? Because with history, we can have accurate diagnosis. And once we have accurate diagnosis, we can set up the right treatment of the patient. With COVID-19, which exposed the weaknesses and the vulnerabilities of the health systems around the world, we find out that there is ethnic gradient, age gradient, and even residential gradient and the professional gradients. It differs between women and men, old and young, and even the residential, where do they live, in which part of our world. And health, of course, we know the determinants of health. Health is in all policies and it's in all aspects of life. And the COVID-19 war, which is a war against the humanity. So we need from all the world, if we want to face this war, to wage a war against the silent enemy, which is killing without discrimination. COVID-19 equalized between all in the exposure, and we all are potential victims in our world, and it turned the world upside down. But the impact, as I said, it depends on who you are and where you are. This disease continues to pose a threat to human security and existence. And when we come to the Palestinian and the Israeli situation, the Palestinian nation is tested on daily basis and life, but they remain steadfast, resolute, determined to get their rights. And of course, they will never give up. But what is important and what is challenging and painful is the world's ignorance and apathy, indifference of these crimes and silences on them without moving a finger for positive action. Even around the world, we see the suffering of the marginalized groups around the world with COVID, and the world is separated and is divided. In the occupied Palestinian territories, West Bank and the Gaza Strip, which is the home of more than 5 million people, which is regarded as occupied territories by the international community. And in this world, we need to have order. And no one is above the international law. We need to have justice. And there has been a sharp rise in infections in the Gaza Strip and the West Bank. And the Palestinians, they are faced with many challenges with access to healthcare, to the most precious thing in life, which is their freedom. And the populations in the West Bank, they're about 3.5 million. And in the Gaza Strip, which is a small piece of land, more than 2 million people, most of them are women and the children. and the unemployment rate, which is more than 50%, and then the Gaza Strip, which has been under siege for more than 15 years. From sea, from the water, from the air, and from the land. But at the same time, it's one of the most illiterate regions and nations in the Middle East. The literacy rate in Palestine is about 97%. And the health system is fragmented, is very vulnerable. It's dependent on donations from other countries. But when you see what is going on in the West Bank with the settlements and the settlers, there are more than 500,000 settlers who are living within the West Bank with the Palestinians, and they have different health system and the discrimination and the land, the resources, the water resources. It's shocking to see that the case fatality rate for these areas is 1.1%. That is the proportion of reported infections which resulted in person dying. In Israel, it's only 0.7%. So in the West Bank and in Palestine, 1.1. In Israel, it's 0.7, according to WHO. WHO data shows that there have so far been more than 250,000 confirmed coronavirus cases and more than 2,500 deaths among Palestinians in the Gaza Strip and the West Bank. So when we come to the vaccination, whose responsibility is it to vaccinate Palestinians? Israel is the leading nation globally for the number of doses per head of population, with more than 108 doses given out for every 100 people. Is it political or humanitarian? It's shame to politicize it. It's time to humanize. And we can use this as an opportunity to humanize and to build the bridges. The United Nations, a human rights body, has released a statement saying it's Israel's responsibility to provide equitable access to COVID-19 vaccines for Palestinians in Gaza Strip and the West Bank. The body says differential access is morally and legally unacceptable under international law. This is in the Geneva Convention on the Regulation of Occupied Territories. And the fourth Geneva Convention is specific about the duty of the occupying power to provide health care to the occupied. Israel has a responsibility as an occupier power to ensure the medical supplies of the occupied people, including adoption and application of the prophylactic and the preventive measures necessary to combat the spread of contagious diseases and epidemics to the fullest extent of the means available to it.
5 minutes.
Israel, we see it. Israel is donating vaccines to countries outside the neighborhood of the Middle East. To where? Czech Republic, Honduras, Guatemala. For what? For political reasons. Which is more important? Where is the priority? To vaccinate your next door neighbor or to vaccinate far where the risk, Palestinians and Israelis, they live and ride the same boat and the dangers are equal and they are a threat. So there are around more than 130,000 Palestinian workers working in Israel. They are commuting. What do they need? They can be carriers and they can cross the infection and spread the infection. So how can Israel be protected where Palestinians and Israelis are interacting? And you know, the virus doesn't know barriers, doesn't know walls of separation or ethnicity or anyone. So it's important to understand that the Israelis' safety, security, and health is linked and dependent on Palestinian safety, security, health, freedom, and well-being. When they vaccinate the Palestinians, it's for their own interest because they are protecting themselves from the spread of this virus. You see, this virus started in Asia, in Wuhan, and they spread to the whole world. What about the Palestinians who are only...
Dr. Isidro, hold on. Now, please, hay una persona que tiene abierto el micrófono. Ahí está. Please, can you go on, Dr. Isidro? We have to suspend, and we only have 4 more minutes for you. I'm sorry. Sir, can you habilitate his microphone?
The virus started in Wuhan and they spread to the whole world. So where is the priority? To vaccinate those who are close to you, just a few kilometers from you, or to go outside to Honduras, Guatemala, and other places? So what is needed to be done? We need to revive hope, trust in the international community and our world. COVID-19 poses a universal challenge, demanding a leadership to promote interdisciplinary and comprehensive efforts rooted in the principles of equality, justice, humanity, partnership, and leaving no one behind. There is a saying, the illiterate of the 21st century will not be those who can't read and write, but those who can't learn the lessons and learn and relearn. This puts the world and the United Nations and the international community under a moral, political, human challenge and testing. Not to be hypocritic with double standards, the international community must advocate and walk the talk, a change in political will. How to replace, and that's what we need, how to replace this COVID pandemic into what? Into a pandemic of equality, justice, and the freedom. Then peace that we are missing in our world will be the consequence of equality, justice, and the freedom. I appeal to all to have this silver lining opportunity, to realize it, to humanize, to socialize, to stabilize, and harmonize instead of politicizing. Thank you so much.
Thank you, Dr. Iceland. You have been inside your time, and it is very impressive to hear in just like you said, in such a small territory of land of people that are basically the same, having such an inequality and health disparity. We hope to talk a little bit later after Dr. Neil's presentation, and as a reminder, I will make a sign, and I will, if I don't see you, I will make a sound as well, so that you know that you have 5 more minutes. Thank you. Go ahead.
Sure. Thank you very much. I'll be sharing the screen shortly. As I said, I might go a couple of minutes beyond because I'm going to try to integrate about 5 or 6 of the student questions in the presentation. So I hope you'll let me do that. Yeah, it's really nice to be with all of you and with our speakers. Iseldine's been a friend for many years, and Javier more recently, but I'll probably be coming to Ecuador, pandemic allowing, within the next year to be at the Universidad Central for a couple of weeks, thanks to Javier. So I will share my screen and, oh, let's see, is that going to be there? And present. Is this okay? Is it seeming like it's sharing? Everything good?
Not yet.
Not yet. Okay, I better get back to it. So share your entire screen. Yeah, that's.
Yes, now we have it.
Okay, there must have been a delay for some reason. Okay, so I'm going to start the presentation now. Still showing? All good?
Yes, it's perfect.
Okay, so yeah, so I'm going to be talking about COVID-19 and divisions. Dr. Abu Alish has really led us in that discussion, and Dr. Maldonado will be going beyond. So I'm sort of in between. I've been involved in some papers, so research about an ecological approach to the pandemic, Canada's response, in particular with vulnerable populations, some research on impact on refugees, since I run a refugee health clinic. But my primary job, the day-to-day job, is as a family physician associated with McMaster University, working in the Kitchener campus and also with a refugee clinic. I work in our COVID center, and as such actually received the Pfizer COVID vaccine. I've had to pivot to virtual care, as many doctors have in Canada. So I probably see under half of the patients in person now that I did before. And our center is has been involved with the COVID response too, in terms of immunizing others, which is done at our site for among other places in the city. And we've just began that in the last week for the more general population, still seniors. My own background as an immigrant from India with my parents in the early 1960s. My parents were both refugees from what's now Pakistan. So my bias probably relates to that background. I do think that the way that we need to deal with COVID risks is having access to treatment dependent solely on health risks. And we have a responsibility within countries and amongst countries to those at higher risk. So those are my biases. I found that COVID has really changed how we treat each other, and that really concerns me. The first picture here is of a park in Toronto. There was a long weekend in May. We were in the midst, having just had lockdown, and people got out in the park. And I was thinking, oh, that's terrible. And a lot of people were condemning these people for spreading the virus and paying no attention. The pictures probably didn't show that people were distancing a bit in the park at the time. And it was my sister, who's also a family doctor, who said, look at these people. Many of them are low-income immigrant families from the apartment. They have 3 or 4 kids in a small apartment, and this is their chance to get out with the kids after a couple of months in lockdown. And just made me think that we have to look at being in other people's shoes. It's much easier for those of us who are middle class or upper middle class to be out. The second picture is of a doctor from Congo in New Brunswick, one of our provinces, who had traveled to Quebec. And once again, he was condemned by the media for bringing in COVID-19. The story ended up being a bit complicated, and I sent a letter in terms of support for this physician who had done things not quite according to the book, but probably wasn't responsible for the outbreak in New Brunswick, even though the premier considered that he was. So for me, this represents how we choose to treat each other. And yes, there's the underlying perception of how risk is, but it's more a question of conflicting rights. The people who want to follow the rules for the greater good, I think, versus those who really mistrust the state and corporations. And there's some of us who might belong to both groups, but for many of us, we choose our tribe or our camp with COVID, and it's not really a left or right issue. And as Iseldine said, there are many divisions with old and young. In Canada, we had outbreaks in nursing homes, catering to seniors, particularly private nursing homes. And there were many papers about this, but many of the workers in nursing homes are also immigrants and people who had trouble living in multi-generational houses with transportation, things that we don't think about when we start blaming people. 81% of the deaths in Canada in the first wave were from in long-term care institutions. But other parts at risk in the US, meat processing plants. And once again, many immigrants from Latin America have worked in the meat plants. People don't have so much that they can distance at work, and again, live in poorer situations at home. And we have to remember that. In Canada, we have migrant farm workers from Mexico and from Jamaica, among other places. And these people were also more at risk in the waves. And part of it was our willingness as Canadians to pay for more for our food. Again, people living in poorer conditions, people without access to health as easily as we have, and to complain about labor conditions. COVID-19 did have a disproportionate effect on newcomers. In Canada, 25% of the case of people are newcomers, immigrants, refugees, and 43% of the cases were among this population. We also found that there were lower testing rates. And newcomers in Canada have faced many barriers over the years. This is a slide from a paper that I had talking about individual barriers, financial, language, cultural understanding, logistics and transportation, institutional barriers with people understanding the issues of immigrants, and then system level barriers. And all of these led to increased risks in general for health issues, but with COVID, we have found that our refugees had access to resources limited, barriers to testing, and then facilities being far away from where they were. People had a literacy divide, a digital literacy divide, and these all prevented people from isolating, prevented them from getting tested, and preventing them from receiving care. So we have to remember that barriers that people face. And these barriers in the US have led to more people dying, Blacks dying at significantly higher than the rates of whites. And the racial disparities aren't because of biological differences, but because of the social and economic differences. And there are many studies which have shown that in Canada, the US, Britain. I'm going to skip through this slide. This is a brief advertisement for my book on underserved populations in Canada, Indigenous, inner city, and migrant populations. I just wanted to say that people have experienced barriers historically to health, and people are willing to do that, to engage in what would be called structural violence, because these people have been considered less important. But the vaccine rates also are lower for or people wanting to get vaccines. And you wonder, why do people who are Asian want vaccines more than whites, but Blacks want that much lower? And of course, people with lower education and people who are more Republican are less likely to get that in the States. But there is a reason for Blacks in particular to mistrust the medical establishment. And there's the infamous Tuskegee syphilis trial, where people were not treated for a very treatable disease because they wanted to see the natural progression of things in Blacks. So we have to think about that when we think about people not getting vaccines. So does class influence our access and mandating personal protection, travel restrictions, quarantine? And I would argue yes, in many ways. These are two CEOs of hospitals, one in the Hamilton area and the other in London, so two university hospitals. And each of these doctors ended up resigning because they didn't follow the protocols in terms of travel, for vacation, or for family that the rest of people had to, and they were telling their staff they had to. And these are things that many of us who are privileged feel we can do that. One of
5
the
minutes. 5 minutes, Dr. Neil.
Okay, one of the questions related to the vaccines and access to the vaccines. And so We've immunized frontline workers, people over 80 are starting in Canada, and then we'll get people who are younger. Indigenous people are also prioritized. And then we get to other people who work in higher risk areas. So there is a plan for that in Canada, but there are people who want to jump the queue, so to speak, and we can talk about that. And I think this slide might look familiar to you, your neighbor to the south. You had the president, the minister of health, the minister of foreign affairs. But beyond that, if you look at the list of all of the people, ministers, but also academics at one of the major universities, Cayetano Heredia, that I've been to and have friends at, that people felt that they deserved the vaccine. They said they were participating in a clinical trial. And this, I think, it has happened rather recently in El Salvador. Again, people who felt that they deserved extra access to vaccines. But beyond that, nations act in that way. And nations earlier in the pandemic hoarded masks, ventilators, and other medications. The US led a lot of that. Donald Trump led this. And we found that that really had significant impact on many other countries. Now, one of the questions was related to COVAX. I won't talk too much about that, although Ecuador just got some AstraZeneca vaccine from the COVAX yesterday. They announced this. This is meant to give medications to the global south, but it's only to have doses for 20% of countries' populations, while the rest of us in the global north get immunized. The vaccine this slide shows is being given in the north, not so much in the south again. These are the yellow ones are the ones where the darker it is, the more people are getting that. AstraZeneca is being given to other countries, but those of us in Canada, the US, Britain, we get the Pfizer or Moderna, the recombinant RNA vaccine. And the question is, why is that? So in the name of time, I'm not going to say too much other than here you can see Canada actually has about 5 times the number of shots per our population with deals with all of the companies, and Britain and the US are similar. And so what are we really promising to the global south? We're promising them that maybe in 2023 they might get vaccinated, having widespread vaccination and trying to achieve perhaps that immunity. And vaccine nationalism could prolong the pandemic, as Iseldine said, that the virus really sees no borders, and poorer countries will be left behind. So again, I apologize you don't have so much time to look at the slides, but I will share those afterwards with the class. So Israel not only doesn't give vaccines to Palestinians that it's supposed to have responsibility for, but it actually gives it to countries that have recognized Jerusalem as its capital in different places, or that it wants to gain favor. But Israel isn't the only country that's doing that. The US just said they would give vaccines to Mexico if they closed the borders. So people are doing this quid pro quo type of things with vaccines rather than looking at basic need. And but while the countries in the West are doing that and fighting amongst themselves, Britain not sending vaccines to Europe, or Europe saying they won't send vaccines to Britain, in the meantime, countries like India and China and Russia are using this much less partially. And they've made they've made agreements to sponsor vaccines in much of the rest of the world, which, and we like to think of ourselves as being more moral in the West or global North. Vaccine passports.
1 minute, please. 1 minute, please, Doctor.
Yep. Vaccine passports are another issue that will divide us. I might be able to come to Ecuador because I will be immunized, but other people won't. Again, and some people can't get vaccinated for other reasons. So this is something that we have to think about. So our main questions to ponder: the interests of people, whether it be politicians, religious, or corporate, but the responsibility of the state and of sharing within and across borders to different ethnic groups, our responsibility to our neighbors, to those occupied, of the north to the south, of countries with access and means of production to those without. And then we have to think individually, what are our responsibilities as individuals and how should we treat our neighbors? So just wanted to put out more questions and answers. Thank you.
Thank you very much. You start this part of the conversation between, you continue the discussion between politics and the incidence in the global problem of inequality, and particularly today, health inequality. Also the ethics of many things that we have been doing this year and that will probably become an issue, just as you say, the immunizations, passports, and many other issues that we sure need to discuss more profoundly. But now we have Dr. Javier Maldonado for 15 minutes, and I will say it in Spanish when there are 5 minutes left of his conversation, of his talk, so that he can have a reality of how far he is from finishing. So, Dr. Javier, le escuchamos, por favor.
Buenos días, muchas gracias. Voy a compartir pantalla.
Good morning. I'm going to be sharing my screen.
Listo. Buenos días con todas, con todos. Primero, muchas gracias por la invitación. Como es costumbre mía y siendo docente universitario, empiezo haciendo una declaración de conflictos de interés. No recibo pagos, becas, invitaciones, cenas, regalos, ningún tipo de financiamiento de la industria farmacéutica, de alimentos, de industrias de tecnologías de salud. No lo cuestiono, pero pienso que desde la academia debemos hacer una declaración de nuestros conflictos de interés, y en este tema también me declaro que no soy de ningún movimiento antivacunas. Quiero empezar mencionando que creo que nunca en la historia de la medicina ha habido un desarrollo tan acelerado de las tecnologías, ¿sí? Actualmente hay más de casi 200 investigaciones en fase preclínica, hay alrededor de 80 investigaciones para vacunas.
Javi, disculpen, por asuntos de traducción, si puedes hablar más lento y tal vez como en párrafos, porque lo que vamos a hacer es una traducción consecutiva. Entonces tú hablas y enseguida Paula va a traducirte.
Perfecto.
Ya estoy lista, si necesitan. Puedes volver a decir porque está muy rápido y no me alcanzó.
Bueno, primero, mi declaración de conflictos de interés. No tengo nada en contra de quien trabaja, ni cuestiono. Creo que desde la academia debemos denunciarlo. No recibo pagos, becas, invitaciones, cenas, ningún tipo de financiamiento de ningún tipo de industria de alimentos, farmacéutica, ni de tecnologías de salud, y tampoco soy de ningún movimiento antivacunas.
First of all, I want to say that there is no conflict of interest here. I do not get paid. I do not get scholarship, invitations, dinner, presents, or any type of financial help of any type of pharmaceutic industry or food industry as well, or technological industry. I am not anti-vaccine either.
Creo que nunca en la historia de la medicina moderna ha habido un desarrollo tan acelerado de investigaciones.
I don't believe that there has never been in the story of medicine speed up research about something, about a medical.
Actualmente están en curso más de 180 estudios en fase preclínica y un poco más de 80 en fase clínica solo de investigación en vacunas. Varias de ellas en América Latina, en Cuba, en Perú, en Brasil, por ejemplo.
There are many cases in which there are a number of preclinical development research, and this is 182, and there are clinical development research, which is 82, all over Latin America specifically, including Brazil, Cuba, and other countries.
Es una imagen breve de cómo están interrelacionadas varias naciones en múltiples estudios multicéntricos.
This is an image of how countries are linked together for multiple research purposes.
Desde que inició las campañas de vacunación, desde la primera dosis que se administró, ya vamos casi 300 millones de dosis administradas, en América alrededor de 20 millones, y aquí podemos tener una primera idea de la inequidad en el reparto.
And here we show how the distribution for vaccines on the first stage has been. As you can see, we have 17,900 in all the Latin America communities, and this is the beginning of the inequality that exists with the vaccines.
Vamos a intentar entender tres aspectos. Primero, la dificultad, o más claro, la inequidad en el acceso. Para esto hay tres actores importantes, que son la población y las expectativas que tiene, los políticos, los gobiernos y la industria farmacéutica.
For this, we will be talking about some specific things, such as the difficulty of getting the vaccine, three main factors, which is the population and their expectations, the politics/governments, and the pharmaceutical industry.
Todos tienen expectativas diversas. La población, digamos, la ciudadanía en general piensa que la vacuna es la panacea. Los políticos, los gobiernos en general, intentan justificar con la vacunación vacíos de política pública durante este año de pandemia, y la industria farmacéutica ve en la vacuna una oportunidad de negocio.
Everybody has different expectations of what the vaccine means for the country, for the people. It means that it's health. For the government, it completes missing stages of government, and for the pharmaceutical industry, it means business.
Tenemos también que...
Voy a interrumpir un momentito porque hay una persona que está jugando con su hijo. Por favor, apaguen todos sus micrófonos porque está haciendo mucha molestia. ¿Será que, y no identifico quién es, pero hay alguien que está haciendo mucho ruido? Por favor, si pueden apagar todos sus micrófonos otra vez. Gracias. Disculpe, doctor Javier.
Y finalmente es necesario resignificar el concepto de vacunas que vaya más allá de la inyección, el pinchazo y el efecto adverso, sino entenderlo como parte de una política pública.
Sorry, we need to understand the real meaning of the concept of vaccine, which is not only to put it, get the shot and that's it, but as well as some public government issue.
Esta es una imagen que había presentado Neil también, y es como la industria farmacéutica ha comprometido vacunas en función del nivel de ingreso de los países, ¿sí?
This is an image that Neil already showed that shows the amount of vaccines that each country has already given.
Perdón.
I'm sorry.
Sí. Y aquí una reflexión también, que no solamente la industria farmacéutica ha priorizado estos países, sino también que muchos países de alta renta económica han comprado vacunas para un número muy superior a lo que necesitaban. Por ejemplo, países como Canadá ha comprado o ha precomprado vacunas para más o menos 5 veces más de su población.
Something to take account here is that we do not only see how the preferences of the pharmaceutical industry works within the countries, but actually see how many of the countries have bought more than they need for vaccines. In this case, we'll be talking about Canada, who bought more than 5 times the amount needed for the population that they have.
Esta irracionalidad en la compra va terminando con las ideas de una salud global, una salud solidaria, y me recuerda al inicio de la pandemia, cuando las familias salían desaforadas a comprar en los supermercados, terminando los productos de percha y la gente de menos ingresos no podían comprar víveres.
This is something that we should take account because it is something that it is damaging the rest of the countries that do not have the opportunity. And this reminds me at the beginning of the pandemic, where everybody rushed to the supermarkets and left them empty, while the ones that who could not reach it did not have substantial things to actually live through the pandemic.
Probablemente esta irracionalidad esté terminando con la salud global para volver a nacionalismos que ya se pensaba superados a nivel mundial.
This could be an issue that could lead to nationalism that we thought it was already over, but it could be a way of getting it back.
El siguiente punto es que en el sur global tenemos pocas vacunas. La pregunta es, ¿cómo las vamos a priorizar? El primer plan, por ejemplo, que salió en Ecuador, hablaba de un plan piloto de 50,000 dosis, cuando en verdad tuvimos 8,000.
Entonces, antes de seguir, tenemos 3 minutos más para terminar esto, ¿ok?
This is an example of the lack of vaccines we have in the southern hemisphere of the globe. And as you could see, the beginning of our first phase of vaccine was held by, podría regresar, Javier, que no, an amount of 800 vaccines and only have reached the country.
Este mapa muestra la inequidad en la distribución de vacunas en América Latina.
This image shows the inequity that there is in Latin America with the vaccine.
¿Sí? Ecuador vacuna 0.05 vacunas por 100 personas, es decir, estamos entre los valores más bajos de la región.
Ecuador is with a 0.05 amount of people vaccinated, which leaves us to the last 5 countries with the vaccine dose.
Ahora voy a pasar rápido, me adelanto en la explicación, con una serie de gráficas que van a mostrar cuántos días se necesita por país para alcanzar el 70% de la población.
I'm going to rush and explain how much there is the need to vaccine daily so that we could reach at least the 70% of the people vaccinated.
Israel, 38 días.
Israel, 38 days.
Chile, 64 días.
Chile, 64 days.
Estados Unidos, 143.
The United States, 143.
Canadá, 467.
Canada 467,
y Ecuador 2.522 días.
and in Ecuador 2,522 days.
Es decir, casi 7 años para alcanzar el 70% de nuestra población vacunada.
Meaning it would take 6 to 9 years to reach the 70% amount of people get the vaccine.
Sí. Aquí nuevamente voy a pasar rápido, es una iniciativa de la OMS para apoyar el tema de vacunas.
Again, I'm going to rush, but this is a help that we've gotten from the OMS to rush with the vaccines.
Son 10 indicadores de listados de la A a la J que van desde el manejo, vacunas, talento humano.
There are 10 subjects that go from A to J, and it goes from vaccines and work.
Y cómo se han cumplido.
And how this has reached.
Este es el global a nivel regional.
This is global, regional wise.
Chile,
Chile,
Ecuador.
and Ecuador.
Bueno, estamos cerca.
Sí, finalmente, la iniciativa COVAX
Leslie, the initiative COVAX
es interesante por un lado, pero no funciona si no hay aporte de los países.
It's interesting, but it won't work unless there is collaboration from the countries.
Pero una lectura más profunda de la iniciativa podría indicarnos que oculta el tema más importante en el debate de acceso a vacunas, que es las patentes.
But a deeper look at the anticipation would be that there is lack of people helping the vaccinations.
Manejada o administrada COVAX por CEPI y Gavi, son dos iniciativas financiadas en un 60% por la industria farmacéutica y son quienes determinan qué vacunas se compran y a qué países se asignan.
CEPI and Gavi are the ones that determine and the amount and where the vaccines are going and when will they be arriving.
Por tanto, el debate más importante que deberíamos tener a nivel mundial es la lucha por terminar con las patentes de las vacunas.
So the debate that we should have, it would be ending the patents according to the vaccine and how it reached.
En junio, en la reunión de la Organización Mundial de Comercio, se debatirá este tema. En el cuadro se ven los países que apoyarían y los que negarían esta iniciativa.
There will be a debate on July that will help us reach this debate.
Finalmente, para ir terminando con la presentación, podemos ver que a un año ya iniciada la campaña de vacunación, el acceso se ve totalmente limitado por una condición de clase.
As we can see, to end this, the vaccine program has been divided by class, and these are some examples.
Con casos muy sonados de corrupción y de vacunación VIP en muchos países.
With cases of corruption and vaccine VIPs.
Con preocupaciones diversas en función de la renta que tiene cada país.
With diverse meaning of regulation that each country has.
Con soberbia indicando quién se vacunó por una condición de clase.
With the fact that who got the vaccine and which class, social class they were in.
Y bueno, finalmente un agradecimiento nuevamente y un cielo bastante caprichoso de Quito.
And lastly, I want to thank everybody, and I leave you with this amazing but confused sky of Quito.
Gracias, Dr. Javier. So Dr. Javier also brings up more issues of ethics, particularly the influence of pharmaceuticals and the lack of decision from many countries, especially the South, because the governments in the South could pressure to avoid or at least make a better use of the patents in order to have more access in a more hasted way for everybody in the world. The other issue is the rhythm of vaccination, which is really bad at the moment, especially for the South again, and South America probably even worse than other countries in Asia. For example, India is doing a great job. As we know, the pace is much better than expected at the time. However, fortunately, that pace is going to be changed every day. Actually, it's changing. So hopefully, it will not take 7 years for Ecuador to get completely vaccinated, but much less time. As long as the vaccines that have been promised arrive to the country. Well, I have I don't know, like many questions, and I have lumped them together in order to have some access. So I will randomly give the questions to the people that have exposed today in order to complete or at least to get a better idea of what's going on for our students and the people that are listening to this conference. So Dr. Neil, one of the things that many people are asking is, how do we get out of this mess? What solutions, being the disparity among the countries, the different health systems, the problems in many countries with corruption and with this belief, just like you said, it is not in the United States, the African American community have a very bad relationship with the health system. That happens also in many other countries. In our country, for example, we have the problem of different types of health provided to the communities and a lot of the distrust as well, not to mention the lack of access for more than 40% of the population. So what do you propose if you were the president of the Health World Organization and you had the power to change things? How will you do that so that it will be more explicit and more efficient for the countries to receive for the poor countries to receive the vaccine?
Mm-hmm. I think I'm much better at citing problems than solutions. I do think that it is challenging, and a lot of this really involves a way of thinking that has to change. I think that even the people who were considered corrupt, and I look at things in Peru, I don't think they're bad people. And when we in the North in Canada, getting 5 times the vaccines than what we need for our population, and even with the COVAX program not sharing, we say we'll look after ourselves first, then we'll look after the rest. That is something where we all have this tendency to look at ourselves before looking at the other. I think it's as with things with climate change, for instance, where we all have to make sacrifices for the good of others and the planet. I think that sometimes people are actually willing to follow rules that are established from outside. And that's been shown in terms of climate change, that people don't change their own behavior, but they're okay when something's imposed and the law affects people for that. So the WHO can set standards, but right now the WHO still is controlled a lot by countries of the global north. The pharmaceutical industry, as Javier says, has abnormal power. And so to change those structures, I don't have a magic answer. So even if Dr. Tedros thought all of a sudden tomorrow, well, I've got to change, he doesn't even have that power. So I think it involves a change in global thinking. We can say that rich countries, for instance, have to have part of what they get, that it's 20%, say, that has to go elsewhere at the same time, not later. You can have rules like that. You can have compulsory licensing, as Javier mentioned, and that's being used in terms of HIV. Countries in the global north have been pressured that way. And then there's naming and shaming. So I hope that those are some ways that we can get to a better solution.
Okay. Now, Dr. Iselden, I will also lump a lot of questions around the curiosity of our students on how to make it fair, basically, the unjust situation that Palestinians are living in the same neighborhood of the one country that is doing the best job in vaccinating his citizens. So they ask, and I will also make a little trick to you. And this is, if you were the president of Israel, not of Palestine, of Israel, how will you do it easily? I mean, not easily, but so that the people from your neighborhood, especially Palestinians, will get vaccinated? Will you wait until most of your community has herd immunity? Will you open the frontier to give it to them? Will you make Palestinians come to Israel? Will you go as Israelis to Palestine? What will be the process, the way you do it? Because we know it's unfair, and after your exposition, for sure, there's no doubt for most of us that things have to change. If you were the president of Israel, how will you do it?
Thank you so much. First, if I want to be there, I will be the doctor, not to be the president, the political president, because that's what is the message of doctors, is to humanize, not to politicize, and to treat all equally. And that's what are we doing as medical doctors. When we treat patients inside the hospital, all of them are treated equally inside the borders. And that's the message we want to take outside, and politicians to take it. Number two, we don't live in isolation from each other. We all, Palestinians, Israelis, Americans, we live and ride one boat. It's not about the national, about the international. Even these countries that they achieved high vaccination rate. What is the value of it? Because the vaccine can start in one place else. And because these days we are moving, we are commuting, we are traveling, the trade, the life. So we want to reach a herd immunity for the whole world. I am not safe as long as others are not, because my safety and my immunity is linked to others' immunity. So I want to immunize others in order to be safe and free in this world. That's what I mean. Each of us to do his part. And I think the world has to collaborate and to partner and not to politicize it. Even in Israel, they succeeded to immunize most of the public there. It's not because they believed in it. It's for political reason. It's about election campaign to use it and to manipulate the situation. So it's time to keep the health professionals to do their job and to collaborate with others. And that's what is important. And also another issue which is needed, of course, about the gender inclusiveness in the decision-making. In gender inclusiveness committees, and include more women on the decision-making table. Efforts to deal with COVID-19 pandemic, because have largely excluded women. Just 3.5% of 115 identified COVID-19 decision-making and expert task force have women involvement. Where are women? Where they pay the major price of this pandemic. So it's time to have it in a comprehensive, holistic, and human approach.
Thank you. Doctor Javier, usted en cambio va a ser el ministro de Salud, ya que hoy renunció, el cuarto ministro en este horroroso año de pandemia para el planeta y para nuestro país en particular. Hay un problema que uno de los estudiantes o uno de las personas en el chat ha escrito, y es que hay países como Tanzania que han decidido que no van a vacunar. El estudiante pregunta qué se podría hacer para que organizaciones tal vez internacionales intervengan en esto. Y yo le hago esa pregunta porque tenemos una situación similar en nuestro país en cuanto hay, al igual que en otros lugares, mucha población muy reticente a la vacunación, por ejemplo, los adultos mayores. Y también hay unas comunidades que han sido históricamente aisladas y que también tienen mucha desconfianza y probablemente van a tener, incluso si hubiera la vacuna, esta actitud en contra de la misma. Desde su punto de vista, ministro, ¿cómo haría para poder hacer que la comunicación sea mejor en un país como el nuestro que está fregado entre la pobreza, el retroceso, 15 años en estándares sociales mínimos y, por supuesto, la corrupción y la desconfianza a los políticos? ¿Qué haría usted?
Bueno, es bastante complejo. Partiría porque ha habido 15 años, por lo menos, de un descrédito hacia muchas instituciones que ha venido desde el poder central. Eso nos ha debilitado a todas las organizaciones sociales. Entonces pienso que lo primero que deberíamos hacer es reinstitucionalizarnos, ¿sí? Creo que lo segundo es, y un poco va de la mano con esto, va a integrar de forma real a la academia, ¿sí? Entonces, claro, tenemos una academia que ha sido perseguida, cuestionada, con profesores que han sido jubilados y que está totalmente al margen de las decisiones, ¿sí? Si la academia no está en ese espacio, lo llenan un montón en redes sociales de movimientos antivacunas o de fanáticos o de cualquier otra cosa, ¿no? Creo que la educación es clave, es importante. Creo que deberíamos tener un sistema de farmacovigilancia sólido, fuerte. Creo que deberíamos fortalecer la atención primaria, que más allá de los discursos y las construcciones físicas, se ha debilitado en los últimos 15 años. Si no tenemos médicos o personal de salud, más bien dicho, con capacidad de dialogar y de interactuar con la comunidad, la ciudadanía va a ser presa de cualquier noticia falsa o alarmista de redes sociales. Entonces, el trabajo es fuerte. Creo que todos tendríamos que arrimar el hombro.
Bien. Well, I'm gonna just ask a couple of questions more, and then we will be closing this because we are running out of time, actually. Dr. Neil, you talk a little bit about how it is not only a problem of governments, of authorities, that have this issue of priorities, and it is also a problem of people. There's a selfishness that goes beyond the individual to the government and to the countries. When we see that, just like the Dr. Iselin show, Israel having more vaccines per person than the countries that are next to them. But it is also a problem of individuals. And now we have the vaccines VIPs, the people that do not follow instructions for biosecurity, the tourism for vaccination, so many problems. How do you see the ethical part of changing this? Because in our country, for example, being that the VIPs are being now shown publicly, they will have some of the bioethical issues are being destroyed. There's no confidentiality, and there is punishment in public for the people that have received the vaccines and so on. How do you see this other part of the pandemic that is killing us. The lack of rights, and the destruction of the few bioethical things that we should have learned by now.
Mm-hmm. Yeah, I think that this will involve a change in consciousness. And Dr. Javier, of course, has studied this issue much more than I have, and Dr. Belin, who's put a question in the chat, has studied that too, that often, as Belin said, that often people in the global south are where vaccines are tested, and then they don't really derive the benefits at the same time. And I think people are starting to become more conscious of these issues. Dr. Abu Aleish also mentioned issues of gender. And I think that we've become more conscious about certain issues of gender or around sexuality. And I'm hoping that in that way, we've seen in the US with Black Lives Matter, we've seen an increased consciousness of what's being done. And I think globally, we are starting to see more discourse around neocolonialism and people who are kept out. So I'm hoping that once people actually are shown what they're doing is patently unfair, and that does involve a change in consciousness, I think that will be the start of things. And as I said, I don't think that the people on an individual level who've been named and shamed now in Ecuador and Peru, that they were not really bad people. They were just people who were blind to their own privilege. And in Canada, we found, say, certain medical professions, even amongst medical professions, there were debates about who should be prioritized. And everybody thought, oh, I'm more at risk and I should be prioritized. So I'm hoping there'll be a change in consciousness.
Thank you. Dr. Aislinn, some people ask about globalization. How do you see the pros and cons during the pandemic of this globalization? I mean, for sure, science have developed vaccines at a rate that we have never seen. And hopefully the studies will show also that there is some solidarity, that there is not only selfishness in the world. How do you see globalization in this?
Thank you so much, really. I want to ask, really, because Einstein said insanity is repeat doing the same thing and then we expect different result. From the time Spanish flu started, we are using the same measures used in the time 100 years ago of isolation, distancing, and masks. What are the lessons gleaned? We need also to do evaluation and what do we want and how do we achieve it? So I think after COVID, which exposed the vulnerabilities of the health systems and the weaknesses, and that we are not prepared. And what is sad, really these days, what are we focused about? About the biological impact of COVID-19, mortalities and morbidities. But what about other determinants of health that we don't focus on? And it's important, one man said, the end is near about the vaccination. But a woman who is wise, she said, actually, this is just the beginning of the pandemic. What is later on? Are we ready? Are we prepared to face the challenges, the other social, mental, economic, financial pandemics? So I think we need to work globalization, not to be nationalistic. As you have seen it at the beginning of COVID, we started to stigmatize other countries and to shame others and to focus locally. We need to strengthen our partnership, our collaboration, and to work together and to focus on, most important, really, education, and in particular to give a role to the academic institutions. Academic institutions and academicians, they have a responsibility. The biggest challenge is individual responsibility, not to start just blaming others. We need to work together, and that's the only way we live in one world. And as I said it, I repeat it, we live and ride one boat in this world, and we must not allow anyone to do harm to this boat if we want to reach the shore peacefully, healthy, and well.
Thank you. Doctor Javier, muchos estudiantes preguntan el sistema de priorización durante la vacunación. sobre todo con la escasez de las vacunas. Y sin duda hay unas guías generales que dio la Organización Mundial de la Salud y algunos países tristemente muy mal guiados, como bien decía usted, con falta de personal académico en las reuniones para decidir estas cosas, copiaron y dijeron, por ejemplo, lo cual está bien, que los geriátricos tenían que ser la fase primera, sin olvidándose que en el Ecuador menos del 1% de la población está en geriátricos, la gran mayoría son cuidados en sus familias y como decía el doctor Neil, en estas familias, en estas casas muy pequeñas con muchas generaciones y tantos problemas que ya se han dicho. ¿Qué explicación o qué recomendación daría usted para estos estudiantes y para nuestro país en cuanto a esto de la priorización, sobre todo visto que estamos con menos del 1% de la vacunación, de la población vacunada de aquí hacia el próximo año?
Gracias. Quería aumentar algo a lo que había dicho antes. Un médico muy conocido que es un líder de opinión, fue noticia hace un par de semanas porque él decía que los médicos jóvenes no deberían ser primera línea, ¿sí? Y claro, la ciudadanía que no está vinculada a salud mira al médico famoso que sale en televisión, al influencer, diciendo que ellos no tienen que ser la primera línea, me genera desconfianza y prefiero no vacunarme. Eso es algo que también deberíamos decirlo, ¿no? Lo otro, claro, comparto, la priorización en Ecuador ha estado muy mal orientada. Se ha hecho una especie de copy-paste de esquemas o de planes de otros países y finalmente hoy en la mañana revisé con la esperanza de encontrar algún cambio que no encontré, quiénes son las personas de los grupos priorizados y poblaciones de altísimo riesgo como personas privadas de la libertad que viven en un hacinamiento increíble, personas en situación de calle o migrantes, gente que no tiene techo y que está en la calle, deberían ser prioritarios porque en estas poblaciones se facilita muchísimo la transmisión del virus. Y si es que hay una alta transmisión del virus, es más probable que haya mutaciones. No es raro que las cepas nuevas que están volviéndose más contagiosas, más agresivas, estén en las zonas de alta migración. Por ejemplo, Manaos con migración venezolana, ¿sí? Por tanto, una de las poblaciones prioritarias deberían ser ellos y no constan en ningún plan. ¿Sí?
Muchas gracias. We come to the end of this discussion, although of course everybody has more questions than answers by the time we finish. I hope that we can help our students between Eric and me. We can certainly answer most of the questions that I read in the students have sent. So we are open to have another reunion only of us. Then I just remember one of my teachers used to say in his campaign against the tobacco, that when a person is smoking, the fumes are all over the room. Same as if we go to a swimming pool and one piece, the pee is all over the swimming pool. That is to say, Dr. Iseldin has said so many times, this is one word and we are all getting the same pee, or in this case, the same virus. So we have to find ways to really give access to not only vaccines, but everything, a good health system, more than anything for prevention and fairness in the way people live in our countries. It is obvious that the deficits that we have in the first war between different ethnic groups, gender, and so many migrants, as Dr. Javier has said, are evident and show that also in the first world, there are so many problems that are not solved and we are not finding the solutions, even though our students are making the right questions, we are still in lack of the right solutions. So hopefully we will keep working towards those solutions and associations between different peoples from the world will probably help more than anything to understand our differences and make a better world for everybody. Thank you very much to Cheryl for putting up these very great teachers and professors and human beings more than anything. And hopefully we will have a better day soon. And we will be together in person to give hugs and kisses as we Ecuadorians usually do. Thank you very much.
Thank you very much, Beatriz, for moderating. Thank you, Javier, Neil, and Iseldine for your talks. And thank you to everyone here for coming and for all of your great questions. And thanks again to Erica and Maria Paula for their translation. All right, have a good rest of your afternoon. Bye.
Thank you.
Bye.
Thank you so much.
Okay.